Welcome to the um, presentation on teaching patients, strategies for children and older adults. Today we're going to discuss teaching strategies for children from a motor learning perspective, discuss briefly the teaching strategies for adolescents, age-related changes, and then strategies for dementia, and then caregiver strategies for teaching and assisting the older adult. First discussed will be teaching strategies for children and adolescents. When you're teaching children, the primacy of the patient comfort is important. You need to ensure that the child is comfortable in order to learn. Caregivers should be invited to participate if possible. Age is not always associated with developmental level. In fact, some individuals may be at a totally different developmental level than they are of age. For example, my 3-year-old was at a 12-month developmental level. And therefore needed to have intervention to bring her to a 3-year-old motor development level. You need to evaluate each child and evaluate their self-care abilities. Play, imagination, role play is important to make learning fun. Stimuli should be varied, especially with visual stimuli. Terms should be simply used and easily understood. Repetition reinforcement should be used, and goals should be development with consistent with development. In determining what things might be important to teach children, you need to consider what development happens when in the development of certain things, such as memory and executive functioning. Implicit memory develops over the first few months. In order to facilitate learning, use the implicit memory, you need to use a conditioning or a procedure to educate for retention. You use adaptive responses or stimuli that create instinctual reactions. For 4 to 8 months, they're pre-explicit. They start to develop attention and recognition memory, which relates to object permanences and can detect new situations. They can start to play. They tend to be attached to their primary parents, so your primary parent may need to be involved in the rehab process. For explicit or declarative, they can start participating in sequencing of events, and they have novelty preference. That begins 8 to 12 months. Recall of explicit tasks or declarative memory is impaired until about 3 years. An individual won't reason until about age of 6 or 7 years, so until then you need to provide direct instructions or either/or choices. Working memory begins at 8 to 12 months and increases until 24 years old. This helps individuals relate past events to present and can be used in the rehab process in order to facilitate learning of new motor tasks. Long-term memory develops over the lifespan, and also word meaning and motor behavior develop over the lifespan with long-term memory. With executive functioning, attention, at 12 months they can inhibit behaviors, at 3 years they can inhibit instinctive behaviors. Impulse control improves up to 6 years, at 9 years they can monitor and regulate actions, and at age 11 some increases in impulsivity occur with the onset of puberty. With information processing, that increases between 3 and 5 years. There's significant gains between 9 and 12 years, and there's minimal change after 15 years. Cognitive flexibility, between 3 and 4 years old, they can switch activities. Between 7 and 9, they can handle more complex tests. These gains continue through adolescence, but at age 13, they're still not at an adult level. In goal setting, 4-year-olds can demonstrate simple planning and ability to set a new goal. Organizational skills start to develop between 7 and 11 years of age, regress at age 12 and 13, and improve during the rest of adolescence. What this means for you is that if you are treating children, you need to consider at what age these things are expected and tailor your intervention to the fact, can they attend to what you're trying to do? Can they process the information? Is it too simple or too complex? Can they switch between activities easily, or should they use a more blocked schedule? And are they able to participate in setting of their goals? Are they old enough? So there's some implications for motor learning. Nervous system development and maturation will affect their ability to learn and master motor skills. Um, with practice, when learning or relearning a motor skill, intensity of practice matters. Children need a high intensity of practice. Young children need block practice to improve transfer of skills, and random practice is not as effective. Typically, developing older children are able to develop better skills when variable or a mixed practice schedule is used. However, if the development is delayed, you should expect that the use of block practice may be a better strategy. With feedback, this is important for both infants and children. You get a stronger response motorically in infants when parents offer demonstration and verbal praise. And infants as young as 10 months old can use intrinsic feedback in learning new tasks. One of the things, if knowledge of results is too specific in children, it interferes with learning. It's better to give them intrinsic feedback that relies on the positioning of the arm. They need specific motoric cues to improve movement patterns. Put your arm here, put your leg here. And they benefit from internally focused proprioceptive or kinesthetic feedback, more than observing the results of the activity. In a new task, a child needs more constant feedback, and they don't necessarily benefit from fading the feedback. In considering teaching adolescents, adolescents are progressing towards more independence, so you need to involve their parents while giving independence and let them make decisions about what activities their parents are going to be involved in and what they're not. Allow the individual adolescent to set their own goals and involve them in treatment planning, and provide them with education regarding conditions that are treated. The role of the parent in caring for a child in PT is to collaborate with the physical therapist to promote development. And when we're educating them, we use strategies of adult education to educate regarding the needed interventions. Parents and families have the primary role in their child's development. We collaborate with the family to provide development and implement an individualized intervention program for the child. We support them through coordination of services, advocacy, and assistance to enhance the development. This can include positioning during daily routines and activities, adapting toys for play, expanding mobility options, helping individuals to use equipment effectively, facilitating safety in the home and community, providing information on the child's physical and healthcare needs, and helping smooth the transition from early childhood into school and into adult life. Now we're going to switch gears. Now we're going to transition into talking about the older adult, including normal aging, and also talking about pathologies or conditions that may affect aging and the impact on aging and caregiving. First, we'll start out with talking about normal age-related changes affecting communication. The first change we're going to talk about is hearing. The reason we're going to talk about hearing is that 25 to 40% over the age of 65 have some sort of hearing loss. There are several clues to detect that the patient might have impairment. First, the patient says that words are difficult to understand. They may tell you that they can't hear high-pitched sounds. They may stop socializing. They may have trouble hearing a conversation in a noisy room. If they add people to the conversation, they can't distinguish who's speaking. The person may only understand when you're facing them, and they cannot understand when you're facing away, and the person becomes frustrated, or they become annoyed when spoken to loudly. We can use some strategies to assess for impairment using the Hearing Handicapped Inventory for the Elderly to detect if there are decreases in hearing. And also, too, we can use some strategies to communicate. First, we can get the person's attention by calling their name, keeping the conversation focused and warning of a change in topic. If we're not understood, we can rephrase. We can use a maximum 3 to 6 foot distance when speaking to them. We cannot try to eat, chew gum, or smoke. Not over-articulate. Not speak to a person from a distance. Reduce our rate of speaking and background noise, and use gestures to communicate for strategies to compensate for hearing loss. There are also some other changes in that affect communication, visions. There are some strategies. We can use touch to enhance communication, bring in other senses, and talk about doing some environmental changes. With voice, there are some voice changes due to reduced respiratory efficiencies, changes in the larynx due to laryngeal cartilage calcifying, mucosa drying out, thinning of the vocal cords, and changes in the oral cavity. These result in an increase in nasality and reduced articulation. We can refer to speech to improve communication, and if it's because of respiratory inefficiency, we can do some intervention to increase the efficiency of respiratory support to help improve vocalization. There are other pathologies that affect communication. We've heard of all of these things before. We are going to focus more on dementia in this lecture, but all of these other things can affect communication. And so they are things that you need to consider. There are some strategies that we can use. With aphasia, we need to be familiar with the level of comprehension and adjust rate, length, and complexity of information to the person. We want to use concrete, familiar vocabulary in short sentences. We use gesture to augment what is said. We can also use written and verbal cues. We can rephrase our questions into yes and no, multiple choice and short answer. Rephrase the message if needed. We need to give adequate time to respond. We may want to let the person we know we have understood by repeating the message, and be patient with them. With right hemispheric dysfunction, we want to minimize external distractions. We want to position ourselves within the intact visual fields, establish eye contact. We might provide orienting materials, provide structured activities, provide cues to keep on topic, and avoid figurative language and sarcasm and simplify directions. In dysarthria, we want to communicate in a quiet environment, encourage a lower speech rate, have the person over-articulate, encourage short utterances, provide feedback about speech intelligibility and loudness level, and be familiar with alternate communication methods that the patient uses. In laryngectomy, we need to make sure we're talking in a quiet environment. We want to consider gestures and other forms of communication, such as written communication. And we provide support and encouragement for use of assistive devices for vocalization. And with COPD, we want to encourage short utterances if we can, a reduced rate of speech, or we can hold our conversation until after physical activity is complete as compensatory strategies. Next, in dementia. These are some strategies that we can use in dementia. If we establish eye contact, using short, grammatically simple, and concrete input. Instead of, I need you to sit here, and then I need you to stand up, and then I need you to go over here, and then I need you to, we can use some more grammatically simple. Okay, stand up, walk to the sink, move this way. Okay. We also want to avoid the use of pronouns, keeping to one topic at a time, providing visual and tactile sensations to enhance comprehension, providing illustrations or photographs, writing down keywords, using gesture demonstrations, and providing multiple external cues, such as name, bracelets, reminder signs, and calendars, especially in the early phases. And we want to share whatever successful strategies we have with caregivers. When we're instructing, what I want to talk to you about, it differs in each stage of dementia. With early stages, the patient has some loss of memory, but can be re-educated. In middle and late stages, one of the really important things that we can do is maintain spatial distances in middle and late stages due to a loss of visual fields in those stages. Some general strategies are to simplify instructions, environmental situations, and programs that are being offered. to explain thoroughly, frequently, and repetitively if necessary, to reorient to time, season, place, and activity, but not arguing with them, to keep a low, slow voice pattern when we're speaking, to avoid change by keeping routine, staff, and environment constant, to keep familiar people in the objects in the environment, using tactile over verbal cues as previously mentioned, to simplify routines in the environment, to train caregivers when and when not to help, to respect dignity and modesty, and to reduce environmental distractions as we're educating. One of the things about dementia as we transition into middle and late stages, the burden of education goes from the patient to the caregiver. So as patients enter into the late stages of dementia, as we all know, we'll be focusing more on the caregiver. Can also focus on managing behavioral symptoms, and those are noted on the slide. Overall, in managing the behaviorals, we want to ask what's causing the behavior, when does it happen, why is it happening, where is it happening, and how is it occurring. These are important to understand what the triggers of the behavior. Those could be a change in the person's care, change in a care provider, the presence of guests, or a request to bathe or change clothes at a different time of the day. We also need to assess for the personal comfort, pain, hunger, and physical needs in this patient that may be causing the behavior. One of the things that can be helped, we always try to do non-pharmacologic interventions first. And so what we want to think about is how to kind of strategize to improve and, because a person can't always explain, figure out a way to ease the behavior. From a behavior or refusal, there are some motivational strategies that you can use in dementia. One is to introduce yourself every time. To you, you've seen them before, you know who they are. However, that patient may not know who you are. We avoid the term therapy. We talk about things in functional terms. We're going to help you walk today. We're going to help you move today. They may not know the term therapy. Let's take a walk, put on a sweater, and make a snack together might be better received. Take your time. It's the first time you meet the person. They might tell you to go away. They may not know what you want, and start to slow down and talk to the person. We always try to validate when needed, and if the person tells you they're tired or upset, we validate what they're saying. We always talk about skill building, and just like in kids, we might try to use more blocked practice or rote exercises. Rote exercises may be rejected, and this we might incorporate more function instead, just like with a child. They are more emphasizing more function and not necessarily let's kick your leg 15 times. That might not work. We incorporate hobby items into treatment, working on something while they're performing a balance activity. We figure out what time of the day works best for them, and that might be an effective strategy. Different people may be also affected, and we can also incorporate family, physician, and fun into the activity. So those are just some general strategies for educating individuals that are older and who may have dementia. Now that we've talked a little bit about teaching strategies for the individual with dementia, we're going to talk about a little bit about the older adult. We're going to start out talking about cognitive changes in late life. There are significant changes, but they vary amongst individuals. Verbal abilities reach the peak in the 6th and 7th decade, and age-related cognitive decline usually does not occur until the 8th decade. So it's really important to think about if you have somebody with age-related changes, those are typically not happening until after the age of 80. With memory, there are very little changes in sensory memories. Short-term memory, there should be no decline except in pathology. And long-term memory, there's some decline, but not very much. There's some differences in encoding or working memory, but this is more with free recall than recognizing familiar things. And remote, there's no decline. The implication of the memory is that older adults especially need to rely on contextual clues when they're learning how to do new tasks. With intelligence, performance on intelligence scales generally declines, but there's no change in the verbal scale. In fact, the verbal scale may get better, and there is usually no change in crystallized intelligence. Problem solving, the decline in problem solving is delayed until the late 6th decade. They may be less proficient on lab tests. This means that rehearsal or elaborative rehearsal is really important for individuals that are older. With psychomotor skills, they may begin to decline in the early 50s, as well as information processing. And then your verbal skills may show no change or decline after 80. With your abstract reasoning, there is mental flexibility or set shifting, and reasoning tasks may decline. This means that older adults may get fixed on a solution and may not be able to transition. It's called functional fixedness. And so we may need, when we're working on problem solving and abstract reasoning, we may need to help them through problem solving novel strategies. Based upon these cognitive changes, there's some implications. We do expect intellectual ranges to be varied, just like in younger adults. Poor performance doesn't necessarily equal poor learning. As I mentioned before, new knowledge should be associated with previous learning. One task at a time, the block practice becomes more important as individuals get older. We want to reduce distractions. We want to space learning experiences appropriately. Just like in the younger adults, allow some self-pacing of learning. We might need to assist in the organization of the learning process. Again, contextual learning is important, and we want to make sure that we want to use as many senses as possible and provide feedback. With intelligence, performance is influenced by health, motivation, and sensory acuity. With crystallized intelligence, which is your sociocultural influences, this is your ability to perceive relationships, formally reason, and understand cultural heritage. This kind of grows with learning and education even after the age of 60. With fluid intelligence, it depends on short-term memory, which is the creation of concepts, perceiving relationships, and abstract reasoning. This may be decline. Again, it has similar implications as mentioned before. With associative learning, this is being able to learn the association between two unrelated items. This affects the pace of learning, your learning environment, your anxiety, and your interference from previous learning. To improve associations, you want to give older individuals time to self-pace and more time to study before testing. Older learners with associative learning tend to be cautious and therefore may not respond, so encouraging a response even if it's incorrect is a strategy to assist. And also too, individuals may have interference from prior learning, and so they need more time to recall and process new information. Information processing has to do with how an individual receives, retrains information, and retrieves information, how they respond emotionally to learning. And this information processing will especially respond to task-based or task-specific practice. Contextual learning is important in older adults, as I previously mentioned. This is placing meaning to activities they're learning. It can decline towards content, but older adults tend to remember context over content. So one of the things is making sure that we situate our activities in the environment in which they're going to be used in order to make the activity meaningful and in order to increase retention. With problem solving, there are some age differences, and problem solving is maybe changed as people get older. Transfer training tends to be a little bit lower, and problem solving strategies may be lower. So one of the things you need to think about doing is, again, walking the person through the planned tasks so that you ensure that the patient grasps what they need to. Mentioned intelligence. Really, there's no decline in intelligence. Motor learning can be affected by disease states, can be affected by muscle imbalance, postural change, and pain. And we can improve this with rehabilitation focused on impairments. And with motor learning, learning mirrors that in earlier life. Some general considerations for teaching older adults is you want to make sure you give more time because learning is slower. Self-paced learning will lead to the best performance. Use concrete examples because it's better retained than abstract. Psychomotor tasks can improve with practice. You need more repetition for recall in an older adult. Again, just like with adults, we consider their learning style and provide information that's in the preferred learning style. We learn in their own environment and progress to varied environments, and we structure the environment and tasks to process information. So that goes along with our motor learning that we talked about earlier. We want to consider physical and psychological comfort with a quiet environment, adequate lighting, ventilation, and room temperature in order to encourage learning. When we're organizing information, it needs to be organized. Visual displays need to be simple. Verbal presentation should be simple, and whole learning may enhance learning. So introduce a task to its goals, break it down into components which are related to whole, address the components, and then reassemble the task. The rate of presentation, tasks should be presented slowly and give ample time to practice. With task choice, again, you want to make sure you think about what activities are most meaningful, and you focus on the activities that are most meaningful in order to achieve follow-through. Presentation of information should be concrete, one step at a time. We should segment tasks to reduce frustration, and blocked or mass practice with guided patterning, tactile cues with a new motor skill is the most effective with fading of feedback. There are some memory strategies that you can use to help individuals retain the information you're trying to get them to learn, such as internal strategies. These are exercises that you can do mentally, composing mental pictures, visualizing imaging, reading materials out loud, using materials to memories to trigger other memories, or external strategies such as using environmental cues to help you remembering. These might be putting your keys in the same place, keeping a date book, keep lists. The other thing is you need to think about patients setting their own goals, and then also realize that you need to be screening for depression in the older adult because it can impact the rate at which people learn. Other considerations related to the older adult include caregiving. Things you need to consider in this when you're educating are care considerations, so who's making the decision, and also to evaluating decisional capacity, so mental status, judgment, and short-term memory. If any of those you suspect are flawed, you need to consult the healthcare power of attorney or a surrogate or a guardian if there's no healthcare power of attorney. There are some common caregiver issues. Most older adults actually are taken care of by the family at home, and so there's emotional, physical, and social strain. And caregivers may have high rates of depression, perceived burden, social isolation, family discord, and for physical health. So one of the things that you need to think about is how we advocate for our caregivers. The other things you might see in caregivers are secondary strains related to work or finances. When is it time for various services? You need to think about resources and eligibility for services, and then whatever family challenges like conflict of care might be. And then we need to be strong advocates to help with caregiving. One of the things that's a big issue for caregivers is caregiver well-being. And the reason why caregiver well-being is important is it influences care recipient health. The decline of family caregiver health is one of the major risk factors for institutionalization of a care recipient. And there's evidence that care recipients whose caregivers lacked effective coping strategies have problems with depression, and the person cared for has a higher risk of falling. They may develop preventable secondary complications such as pressure sores and decline in functional activities. Evidence indicates that cognitive behavioral interventions to help family caregivers benefit their care members as well. As caregivers experience decreases in depression in response to treatment, so do their care recipients. Care recipients may be at risk for encountering abuse from caregivers when recipients have pronounced need for assistance, and when caregivers have pronounced levels of depression, ill health, and distress. Therefore, there are some ways to assess caregivers. This is a complex process, and it involves assessing individual psychological symptoms of caregivers, and sometimes assessing symptoms of psychopathology in care recipients, and understanding the demands to which illness and disability impose on the individual family, which determines, and we also have to determine the circumstances which predispose the caregivers to positive or negative experience during the period of caregiving. Things you need to address is situation, the caregiver's immediate questions, challenges, and priorities, the family's understanding of approach to the illness and disability, and the family's caregiving stage in response to the progression of the illness. The context, where are they in the development, how are they taking care of young children, late life family, what are their capacities, personalities, and willingness to take on new roles, and what does the family system look like? And then the meeting, or what are the family's previous experiences providing care to an ill or disabled loved one. Things you can ask for caregiver intake are, who are the caregivers in the case? Basically, because care recipients can receive care from a variety of people. What evaluations have been done? And the follow-up questions to this are they adequate? Do you have the results? What have you been told? What do you understand or not understand? To what degree do you accept the diagnosis? What have you learned previously about this illness or disability? What is the etiology of it? What's the expected course of treatment or the course of the condition? And how will care demands change over the illness timeline? Also thinking about the family context of care. So what is the family's developmental stage? Who's taking care of whom, and how many other people are they taking care of at the same time? Who are the primary and secondary caregivers? How much stress and burden are they suffering? And what are the contexts of the caregiving experience? And in what stage of caregiving are they? And what resources do they need? Our role in supporting caregiving and education of our caregivers is supporting level of care decisions by providing information, involve client and family. We need to know what community resources are available, work with the caregiver and patient and task together, and this should be done at small amounts of training time and with adult learning principles incorporated. And we talk about the balance of safety, independence with home assessment and modification and function. So this concludes our presentation for the day, and if you have any questions, feel free to send me an email or a message on Canvas. Thank you.